We are good. Yeah. So, all right. So everyone, sorry. This is Dr. Betty. She's from Reborn Pelvic Wellness. We are so happy to have her back. We've been talking for like the last little bit to try and see when we can get her in. So she's very busy and we're very glad to have her. So I'm going to give her as much time as I possibly can. So have fun.
So like you said, I'm Dr. Betty. I own Reborn Pelvic Health and Wellness. We are pelvic floor physical therapy. And so who's been to physical therapy before? Okay, great. Awesome. Who's been to pelvic floor physical therapy before? All right. One of awesome. It's awesome. Yeah, you got a rating fan. Who's been to Reborn? Reborn? Yeah, Reborn. Great. So I'm going to kind of explain what is that, because a lot of people have misnomers about like what pelvic floor PT is. A lot of people think it's Kegels. And I'll be the first to tell you that it's far from that. And it's much more complex. If Kegels worked, one, they would work and we wouldn't have issues. And two, we wouldn't have a job. So I'm so glad you're here tonight. And what we're gonna dive into first is what makes a pelvic floor PT. So I like to tell people we're physical therapists, we're orthopedic physical therapists, and we're pelvic floor physical therapists. So we're kind of like the nerdiest nerdy of nerds. And didn't stop learning until we arrived at the pelvis. And we're like, oh, this is the missing piece. We connect all the dots together because the pelvis is really the cornerstone of movement. And so we figure out, what's going on that's connected to the pelvis and inside the pelvis to figure out like what's going on with you. Why are you leaking? Why do you have low back pain? Why do you have pain with intercourse or any sort of combination of those things and many more. So when you come into CS, we'll do a full body movement analysis on you from head to toe. We'll watch you move all different directions, squat, balance, maybe lunge or run, depending on what your activity level is and what's appropriate at the time. And then we'll switch gears and dive deep into each area of your body. We'll look at your entire spine. Do you want me to be wearing a mic?
No.
Okay.
My voice or
it's got it. Okay, good. I just thought about that. I was like, I'm not mic'd up. And then we'll look at the entire spine. We'll look at the rib cage, the breathing patterns. We'll check out your abdomen. We'll look at your core engagement. We'll check for diastasis recti, which is the separation of your abs. We'll assess where your organs move. We'll look at your low back, your hips, your SI joint, pelvis, pubic bone, tailbone, all the way down your feet. All of that's external at first. And then obviously with consent, we'll do an internal exam. So similar to an OB or midwife or gynecologist with an internal pelvic exam, it can be done either vaginally or rectally. And then we'll, obviously with consent, and then we're looking through the lens of the PT. So we're gonna look at range of motion, strength, coordination, trigger points, scar tissue, pressure management, prolapse, and all those things together to figure out, okay, what's going on inside the pelvis, what's going on outside the pelvis. It's usually a combination of both that is causing whatever symptoms you're having. And we really play detective through that to get to the root cause. And so a lot of people are like, what does that pelvic exam look like? I run my pelvis. And we'll go over that just so you can see what that's like. So everything in white is bone. Everything in red is muscles, right? And that's your pelvic floor. Wow, right? And so even when I was in PT school, it's like, okay, here's all these muscles and you learn all the things and it's like, and here's the pelvic floor, moving on. Right? It's like, oh my gosh, we just left off a very important piece. So when we do an internal exam, you'll be laying on the table like this. There's no stirrups and no speculums or anything like that. We just use glove finger to assess the pelvic floor. And so you'll be laying like this. This is to orientate you. Here's your pubic bone. Here's your sits bone. Here's your tailbone down here. You have your clitoris, urethra, vaginal canal, and rectum. You don't have one of those canals if you're a man. Darn. And then we'll ask you to do like a contraction or a Kegel. Relax and bear down so we can see what the range of motion and coordination of that is. We'll ask you to cough. What happens when you cough? Does your pelvic floor just like give way? Does it contract and brace for that? What happens? And then with obviously consent, we will touch or palpate around on the outside of the muscles first to examine, okay, what's happening there? Is anything tender? Is anything recreating your symptoms? And then we'll go into each layer of the pelvic floor. Right? How many people know how many layers the pelvic floor there is? Ooh. 3. Close. Yep. So there's 3 levels, layers to pelvic floor. This is the first layer right here. Second layer is on the back. Your pelvic floor doesn't do this part. This is on the back side here. And then this is that third layer. And so it conveniently, knuckle depth is related to the depth of those layers to the muscle. So we'll insert the finger up to the first digit. in the or the first knuckle of the digit, in the vaginal canal or the rectal canal to examine that first layer. Then second knuckle, second layer. Third knuckle allows us to reach all of these along here, all the way back to the tailbone, all the way around to the side. This is actually a hip muscle right here on the side and a hip muscle over here. So we can access some of your deep hip rotator muscles. Obturator internus. Yeah, you're like, what muscle is that?
She said so.
No, obturator internus. So we'll assess all that. We'll see if there's any pain, tension, trigger point, scar tissue, and how do you contract and relax. What does that pressure look like? What have you go down? Do you have any prolapse, which is falling of the organs, which could be your bladder, your uterus, or your rectum falling into the vaginal canal to assess those things. And so that's kind of like what that internal assessment looks like. So totally different lens than any other medical practitioner that would do an internal exam. And so we take all that, combine it all together with the external things and figure out, okay, you're leaking because of this, and you're leaking because of this, and this, and this. Because all of you, if you came in and said you were leaking, it'd be for all different reasons. And so we want to figure out like what individually with you is going on, and what's the root cause of that. I know that's a lot of information all at once. What questions do we have right now? And then I'll keep going. Any? I'll keep going. Okay. We have a chance. Okay. So one of my big soapboxes is I love to talk about pregnancy and postpartum. And we see people through the whole lifespan. You see teenagers that have painful periods all the way up to, I think the oldest person I ever treated was 93. Stopped her from peeing her pants at 93 years old in 8 sessions. Just gonna give myself a pat on the back for that one. Yep. So you carry your pelvis with your whole life, and so we can work through all those different stages. We really love pregnancy and postpartum though, because it really is a time of rapid change that happens. And if you think about it, it's probably the biggest musculoskeletal change you'll ever do, because you broke human and then you give birth and either comes out the vaginal canal or through the sunroof on a C-section. And so that can really disrupt a lot of things. All natural things that are supposed to happen to give birth, but still takes a toll on your body. And so if you were to tear your ACL in your knee or your rotator cuff in your shoulder, when would you start rehab? Immediately, right? How long would you do rehab for? As long as it takes. Usually 6 to 9 months, right? So you can reach overhead, throw a ball, walk, run, do stairs, all the things, right? So what do we do when we get pregnant and give birth? See you in 6 weeks. Come back in 6 weeks. What do they say? You're cleared. Go back to doing everything. Does anyone else like righteously agree with me? I get so upset about that. Yes, thank you. Thank you in the back. So that's really what we're passionate about, is really getting ahead of that and actually doing prehab during pregnancy, because a lot of times as your body grows, the things that are kind of a magnifying glass is shown on musculoskeletally and orthopedically that maybe was subclinical before, it starts coming out, and you're like, oh my gosh, my right SI joint pain is hurting. Oh my gosh, my pubic bone. Oh my gosh, I can like all these aches and pains, and it's like, well, none of that is normal, and we can do something about that. And we love partnering with chiropractors like these guys here, because we work on both ends of the nervous system. So chiropractor, physical therapy, school practices are separate, but here's our scope of practice, right? So we can do each other's jobs, we just hang out over here typically. And so we love when chiropractors are also working with us as pelvic PTs. They work on all the nervous system with the alignment of the spine and things flowing out. And then we work on the nervous system on the other end of like all the musculoskeletal stuff going in with all the manual therapy we do, all the movement retraining we do, dry needling, and we'll get into that in just a second. So we really are really passionate about let's see you during pregnancy and then postpartum, and then continue. You maybe have another pregnancy, maybe you hit menopause, maybe like all these things are shifting because you carry your pelvis with you all the time, and you poop and you pee. You have sex almost every day, maybe not all of them, but you get the point, right? So you're constantly using your pelvic floor with every single movement you do, single like elimination thing you do or pleasure you do. And so it's really important to make sure you're taking care of all of that stuff so that it's functioning properly. No one likes to pee their pants, no one likes to have constipation, and no one likes to have painful sex, right? So all really important things. So what I want to touch on next is dry needling. Who's been dry needling before? No. Did you get dry needle?
No, they were going to, but then they tested and said I didn't, but I think I do need it now.
You're like, maybe I do that, yeah. So I'll talk about dry needling next. Everyone's heard of acupuncture, right? You're like, I know what acupuncture is. That's Chinese medicine, chi energy, put needles in, leave them, does its thing, it's easy. Dry needling, not that. Dry needling is the same needle, but we're sticking the needle into a muscle belly, which has either trigger points or knots. You probably know it's not here, right? So normally your muscles contract and relax like this. When there's a knot, it gets bound down and doesn't slide like it should. And so physiologically, I'm gonna nerd out for a second here, is blood flow drops, oxygen drops, pH drops, all these neuropeptide chemicals sit there and signal to your brain, ow, pain, dull, sharp, stabbing, tight, whatever your brain's perception of that is. Pain is a very complex thing. That's like another lecture for another day. And so you might have a different sensation than versus you. And so we take that needle into that trigger point or knot and create a local twitch response. And it goes like that, okay? You know, like when your eyelid twitches? So it feels like that twitch with some spicy, sparkly electricity, even though you have no electricity hooked up to you. You are electric being yourself, right? Nervous system. You know those rock pop candies that you heard of kids? It's like, kind of feels like that in the muscle. And then it's also like walking into a haunted house knowing something's gonna jump at you. You just don't know when. So it's a little startling too. You're like, what's coming? Oh, there it is. That makes sense. So it's unique sensation for sure. Once that happens and it goes like that, blood flow increases, oxygen increases, pH restores, all those neuropeptide chemicals release, and immediately you have better range of motion, better activation of that muscle, less pain, less tightness, all the things like that. And it's a game changer for us clinically to be able to use dry needling. It's life-changing for patients because it's like instantaneous stuff and stuff that they've had for years or whatever. I'd like to tell people too that dry needling can be very immediate, but it's also cumulative. So like one needling session, you might be like, oh my gosh, I felt great for like a day. And then you're like, and now it's back. Normal, okay? So we need a couple of those sessions to get everything working. While at the same time, your teeter-totter here is gonna be like, oh wow, that's great. But we haven't worked on reprogramming your motor patterns or your movement patterns of like, how do you hip hinge, how do you squat, how do you deadlift, how do you engage your core? So until we practice that, which takes time, and to build strength, does anyone know how long it takes to build true strength? 6 to 8 weeks, right? So it's not immediate. So as you're building that resilience in your body, we're needling and doing a bunch of other manual therapy things to help work with your nervous system. And then all of a sudden it's like, oh, wow, this is great. So you might do a little bit of this back and forth until you feel really good. And then that's usually when you're symptom free, you're not having pain, you're not leaking anymore, you're doing all these wonderful things. You're like, I don't even think about my pelvic floor anymore. Great, that's normal. You shouldn't be thinking about it, it should just work, right? So is anyone like mind blown by dry needling there? Pretty cool, yeah.
Question, yeah, like using the pelvis, like how would you dry needle
The pelvic floor.
the pelvic floor?
Great question. Love that question. I either get 2 people in the audience who are like, can you needle the pelvic floor too? Or they're like, you don't needle the pelvic floor too. And it's, yes, we do. So how we needle the pelvic floor depends on where it is in the pelvic floor. So if you look at the pelvis by this way, it sits kind of like this. So on the vaginal canal, the front half of the pelvic floor, we insert vaginally, and then our finger will be basically the backdrop. The needle comes in from the outside to our finger. Does that make sense? So we have our finger on the muscle on the inside, and then we know where we're putting our needle, and that way we take it right to where our finger is. We can feel the needle approaching. And so like, that's how we hit the front side of the pelvic floor. For the back half of the pelvic floor, it needs to be a rectal insertion for safety reasons. You don't want me to puncture your rectum and take fecal matter to other places it shouldn't be. And so we will insert rectally, same thing, have our finger on the back. I can't put my finger through this rectum. Just pretend my finger's through the rectum. So we'll go in through the glute to then hit our finger on the pelvic floor here. We're not gonna poke our own finger, right? We can feel that needle as it's getting closer, and then we get right on top of our finger and hit those trigger points there. Game changing. Also, if you have scar tissue at all from childbirth or scar tissue from a C-section, we love sticking needles in scar tissue. Game changer. So if you have like sensitivity on your C-section, or you're sex, or that scar just doesn't move, we can stick needles in it. We do it a little bit differently. We don't do quite the like trigger point, hit the trigger point with that. What we do is and it sounds barbaric, but trust me, it's not, you don't even feel it. We stick the needle in and then we twist it. And what happens is that fascia, do you guys know what fascia is? Spider web material all over your body. That fascia kind of wraps around that needle as we twist it. We have special fascia needles too that are a little bit more abrasive that can kind of grab the tissue and pull it. And then we just let the needle sit there. We talk, we breathe, we do little things, and then we come back. And what happens is that because your nervous system isn't threatened, but it's put on a stretch that's non-painful, it says, oh, I should probably adjust to that. And like, let's go. And so we pull the needle out. I'll literally assess someone's scar tissue like this and be like, oh, that's so painful. I can't, like, barely touching. Like, okay, let's stick the needle in there. Stick the needle in, twist it, let it sit for a little bit, pull it out, come back, and I'll like stretch it all the way down there. They'll like literally sit up like this. Like, you did not just do that the same, like I did more, and it went all the way down to the bottom. So you're good. So it's pretty magical.
How long does it usually last?
It really depends on the person and how much is going on. So some people immediate relief and they like, it's a miracle thing right then and there. Some people take, like I said, cumulative couple sessions and how many body parts are involved. So like maybe the pelvic floor is involved, but also this right hip is involved too. So we want to make sure we get everything moving ideally. Similar to chiropractic, right? We want to come in and make sure, okay, everything's moving how it should. It has good mobility. It's stable as well. So we come around all those things to make sure that it like, you have lasting relief with it. Yeah. Any other questions on dry needling? I could talk about dry needling for days.
How often do you have patients that are just like so scared of dry needling? Like, what do you usually go for first, like help them?
Yeah, so that's a great question. So obviously if someone has a true like needle phobia, we're not going to do that. We have other tools in our toolbox. Most of the time we trial an area first. So like the low back's a really good area to trial. And people tolerate that really well. So we'll stick the needle in the low back and hit chiropractic will appreciate the multi-today down there. And so that can help stimulate the proprioception and awakening of that, like, oh, I should stabilize the spine a little bit more. It's not as intense as other places. And so we'll start with that. We'll see how their nervous system responds. So someone who maybe just got in a car accident, found out that their dog is dying and comes in, probably might not want some needles today because their nervous system is really rev, and we're doing a direct interface with your nervous system with the needle. So some people might respond to that and be like, oh yeah, I need needles, I know it's gonna calm me down. Where some people that just might throw them over the edge and they might just cry and like all the things. So we want to be respectful of everyone's nervous system. We want to trial it out, do a couple twitches, see how they respond. How long are you sore for? Because you can have some post needle soreness. So it's similar to a workout sore because that is a maximal muscle contraction that happens, and it's just sore in that one muscle spindle or wherever we do a couple of those twitches. But you can feel it. You're like, oh man, I feel like I worked out real hard there. And that can last anywhere from a couple hours up to a couple days. Now, if someone's pretty active, I'm like pretty sore for like 3 hours max, and then like gone. I'm like, ooh, I feel so good. Or some people are like, oh, I'm sore for about a day. Great, still good with that. 48 hours is kind of our max. If we go past 48 hours, it's usually what we would consider an overdose of needling. We can't really like overdose someone, but it's like it was overdose for their nervous system, where it was like, whoa, that was just too much for my body to like really handle. It'd be similar to like when you're in high school and you play volleyball and you like worked out 2 days or 3 days and you're like, I can't even sit on the toilet, right? So it's like, it's not a bad overdose. It's just like, oh, we might want to not do that so you can still function. So, and then we have some people who are like, all the needles head to toe, and some people are like, you can do one spot. So everything in between. Yeah, did that answer your question? Okay, great. Any other questions? Any other questions on me?
I've like heard some people, right, like, oh, got dry needling and they like, it's worse, if that makes sense.
Oh,
Yeah, so.
what kind of, my question would be, what kind of drainage?
Exactly.
They do?
Yeah, that's what I was thinking.
There's many different kinds, so I'll get on a mini soapbox with that. There is a company that I strongly believe in called Biopain Seminars. They're the original dynamic company that brought it to the US. And they, and since they brought it here, there's now 50 other companies that teach draining. And theirs is all very research-based, scientific evidence, like very structured, safety, they do everything. All their teaching techniques are done under guided ultrasound to make sure this is where we're going with the needle, this is how we're going to teach the technique from a safety standpoint, This is why we do trigger point versus just stick needles in, like electricity on. So I think it really comes down to the practitioner and what they're trained in, and then also the skill set of that practitioner, because you shouldn't be worse. Yeah. With anything, right? My opening seminars is the company that I make all my therapists between. I'm a little neurotic on that. Like, this is where you will be taking your coursework. I know in Utah, there's not very many people who do that because it's a very newer in Utah. It's a very East Coast thing for myopia. Yeah. Any other driving things? Okay. Next, I'm going to talk about prolapse. Who's heard of prolapse before? Yes. So that's where your organs are falling down, right? And so one thing that we do that differentiates us from a lot of pelvic floor physical therapists is we can fit pessaries. Anyone heard of what a pessary is? No, great. So pessary is similar to like a menstrual disc or a menstrual cup. It's an inserted vaginal device that kind of tenses everything up. So there could be a cube, there could be a disc, a dish, all sorts of things, knob for the urethra to help with stress urinary incontinence. It's basically a device that goes in the vagina and holds up the bladder, the urethra, the rectum, the cervix, and the uterus, if there is one, to make sure that you don't have symptoms of like my vagina is falling out or heaviness and pressure and things like that. So we do that. Typically, there's two-thirds of conservative care before you would have surgery is like pelvic PT, and then there's a pessary as that last second 2/3. And then if a pessary doesn't help you or any of that other conservative care doesn't, then it would be a surgical thing. But most of the time we're able to prevent surgeries. Obviously, there's also reasons for surgeries to happen too, but we can prevent them, push them off, change people's lives where they're like, oh, I don't have to do this surgery, or don't have to get a hysterectomy, things like that. By just utilizing the pessary.
But old school, there was nothing.
Old school, yes.
Because I have so many friends that they have said
Yes.
they didn't, because I told them, oh, you should go get, and they're like, no, we didn't know.
I
But
know.
just, you go to your gynecologist.
And they're like,
general-
we'll just do
And it
surgery.
was just a hysterectomy, period. There was no,
Yeah.
there was no other discussion.
Yeah.
So it's awesome that
Yeah.
people have a choice.
Yep, absolutely. So it's huge to just educate people that it is an option. And that's honestly like what kind of stirred a little fire in me to even start Reborn in the first place, because I was working in pelvic health. I had my kids already. I was all in on pelvic, and then the hospital system I was at, which was great. No hard, no fall on them. But all the women I was seeing was post hysterectomy, post bladder surgery, post all this stuff, and they'd never been to pelvic PT before. And they'd come in by visit 5, they'd be like, oh, how come you've helped me so much more than this surgery did? Like, why didn't I do this first? And it was just killing me. Like, yes, these people still need help, as they still do. But I was like, how do we go upstream? How do we work up so that this doesn't even become an option, right? And thankfully, there's now guidelines out there for the Eurogyne guidelines. There are, if someone has prolapse or leaking and things like that, like the evidence is grade A, pelvic PT first. But do they follow their own guidelines all the time? No. So we're still very much fighting the medical system failure of like actually following clinical patterns and guidelines, and what their own organization puts out. We didn't even put that out. That's what they did. The urologists and urogynes have that as in their practice acts and statements. It's like, well, shouldn't you follow your own advice? But they are also, that's what they do, surgery, medications, injections, right? So it's good to know that there's options and good to be able to speak to that. Yeah.
And does insurance recognize it?
Pessaries or in general? Yeah. So from a Eurogyne and stuff like that, they'll recognize it. If a PT builds it, they do not, because we, of course, are late in America. We just were able to do that as of a year and a half ago. Coming up on, it'll be 2 years, I think, April. Everywhere else in the world with pessaries as a physio, except for the United States. Really makes a lot of sense, right? So we got approval as a national organization in the US to be able to do that. So we flew in this last April an Australian physio who's been doing it for 25 years to teach us. So we're like doing all the cool stuff, right? So insurance does not recognize it from PT filling it. We tried. We're like, well, we're gonna submit it and see what happens, and they just deny the whole claim. So we have to take it off. Yeah, it's unfortunate. But we still get lots of referrals from people because the OB-GYNs and the gynecologists, they don't like to fit them, first of all. And then most of the time they have pelvic floor dysfunction that needs to be fixed before they can get fitted. So it just makes sense for us to be able to do that. It's a natural path of progression. Yeah.
Does it fitting entail?
Yeah, for a pessary?
Yes.
Yeah, so we would do the evaluation, work on all the things we need to work to be like, okay, now we're ready to fit a pessary. We wanna make sure there's no pain, everything's moving well, we've done on the mechanical side of things. And then, depending on what's going on, so if they have fully intact pelvic floor that has no like damage or anything like that on one side, we will assess like inserting our thing, plus pretend that this is, actually, we'll use the cups. So we assess, this is called the levator hiatus. So we insert 2 fingers and then test to see how wide it is. And then we'll have them squeeze, things like that. Then we'll test the length of the vagina. We do all this measurement stuff. And then based on what we're measuring, then we'll do the size of the pessary. And then depending on what their symptoms are, if it's prolapse or if it's leaking, we might add a knob onto it to put like almost like a bumper against the urethra to give pressure. Because when you have pressure coming down through your abdomen, this gives way naturally. And if there's too much fascial damage or too much fascial stretch, not in the muscles, in the fascia, then you might leak. So we can put a pessary in that puts like a little lock here. So when pressure comes down, it actually compresses the urethra and you don't leak. So it could be like cool things like that. So it really just depends. And then if someone has prolapse in all directions, we might use a cube or a Gellhorn that actually like props up or takes up space and pushes things. So it really, we like do a lot of like measuring, feeling, okay, cough, bear down, and then we'll fit it in. We'll have you stand up, let you pee, squat, move around, make sure you can't feel it. Test it out, make sure it doesn't fall out as well. It's that.
It's amazing.
Yeah. Wild, huh? Never would have known. Okay, what other questions do we have? Questions?
I
Yes.
don't know if we're gonna want to get to this, but the biofeedback.
Biofeedback.
Yes.
Yeah.
Can you explain a little bit?
I'll go on a soapbox on that one for sure.
That is, yes, please.
So biofeedback in general is a big term that's like, okay, you could be sitting on a chair and getting biofeedback. You could get biofeedback from a finger. You could get biofeedback from a probe that's hooked up to a computer that's like telling you information. Biofeedback is simply something that's telling you about something else, right? So when you think about biofeedback, most people think it's like, okay, let's insert a probe, let's hook it up, let's have you contract, we'll watch the thing rise, relax, or watch it drop. Let's see you do some quick flicks, squeeze, relax, and you like watch it on the computer. That's what most people think like biofeedback is. Now, does that have a time and place? Absolutely. Does it most of the time? Absolutely not. Most of the time, we are not so worried about biofeedback. We're more like, okay, let's see, can you contract? Can you relax? Can you bear down? Great. You have full range of motion, you can coordinate, you want to make sure all those things happen first. Sometimes people need a little bit more biofeedback, but oftentimes just some tactile feedback of itself can be enough. And so I'm not gonna bust out a $10,000 machine to like, let's see if we can do this when I can get it done in 2 seconds with the finger. And then also, most people don't need consistent dosing of that. We want to get you functional as fast as possible. So you're not going to go home with a machine and sit there and be like, oh, let's contract and relax. So they do make those. You can buy them on Amazon for like $120, which are great. And we do recommend that sometimes, but a lot of times we're like, okay, yes, you need this. We want you to purchase this, do it at home. We'll make sure you know how to use it. But we don't want to take our valuable session with you to necessarily sit there for an hour and be like, okay, and do this program. Not my jam. 10 minutes, okay, perfect. And then most of the time, if you can contract, relax, and you're coordinated, we're gonna get you up squatting, lunging, deadlifting, all those things like that, because you will utilize your pelvic floor more during those than actually just doing a Kegel. Actually, by research, we already know that. Like squat, you're actually pelvic floor is contracting more than a Kegel itself. The only time you need to be able to do a Kegel is like if you're coughing or sneezing, you brace against it. It's like you have to have that reflexive. Yeah. No, I love your questions. Keep going.
Question, so I work in sex education.
Ooh.
I work a lot with people that have business.
Yes.
So is your approach like any different to someone who's like terrified? and
Yes.
has way too much tension. So like,
Yes.
how do you kind of go about helping someone that's coming in because they genuinely can't have penetration during sex?
Yes.
Their muscles are so tight.
Yes.
I always like refer them to
Yes.
a therapist, but I'm like,
What
it's
do
a
they actually
procedure,
do?
so I
Yeah.
can like tell them ahead of time.
Yeah, so from a vaginismus standpoint, which is basically vaginal canal is really tight, doesn't move, like can't get anything in, whether that's tampon, speculum, penetrative intercourse, anything like that. And so we, one, are very trauma informed, and we will walk everyone through that. Two, we're never gonna force anything or do anything like that. We need the nervous system to relax. A lot of times the pelvic floor can be stuck in the middle of something. And so there's what I like to call, and this is a Bettyism, this is not like in the textbook. There's vaginismus and then there's functional vaginismus. Functional vaginismus is when it's like pelvic floor is just caught in the middle and like it's really fast. We can move really fast. So like a lot of times we'll lean over the low back and the inner thighs. It's all connected in a fascial line. We'll work outside the pelvis and then we'll come back to the pelvic floor and all of a sudden it's like moves just fine. So it wasn't really truly vaginismus. It was something else. And then there's true vaginismus where it's like the hymen is closed over, which is the remnants around the vaginal opening, or there's vestibulodynia, where there's just so much pain there. Maybe it's neuropathic, so it's like you have to do a vestibulectomy or a hymenectomy, where we don't do that, but we're going to test to see like what's going on. So it's a very deep dive into those things. If it's the functional side, which we see a lot more of, they're just globally diagnosed. It's like, oh, you're vaginismus. Okay, and then we come in and we're like, we'll see if you actually have vaginismus. And that's true in chiropractic, right? It's like, we'll actually see if you have sciatica, or right? So that I'm gonna lens out to that fascial line. There's a fascial line called your deep frontal fascial line from your head all the way down to your toes. It goes from head, your jaw, neck, diaphragm, low back, hip flexors, pelvic floor, inner thighs, feet. So a lot of people who have jaw pain and plantar fasciitis, usually have pelvic pain because it's all trapped in there. And then oftentimes we'll, like I said, we'll needle the inner thighs, we'll needle the low back and hip flexors, and then all of a sudden their pelvic floor just moves fine. I'm like, what's the pelvic floor? It was just caught in the middle. So yeah. We also do like dilator work with those people too, if they have true vaginismus. So the dilators are all graduated, so we'll have them work on even just like themselves touching with the dilator, self-touching of like, here's my pubic bone, here's my sits bone, here's the other sits bone. Because a lot of times this has been shut off, shipped to Australia, I don't want to like, right? So we have to reel that back a little bit and say, okay, here we are, let's touch these things, where are you at, map it out, because we want to map it in their brain too, so that it's safe for them, having them do it, and then eventually we'll, whenever it's appropriate, we'll intervene with that too, and then we'll have them use dilators to insert. We'll have them maybe insert the dilator, wag their tail, pelvic tilt, move their legs, and get movement involved with the stretch. And so we'll layer all those things in and then graduate them all the way up. So yeah, I'll tell a quick story here. I had a patient who was married for 5 years, had never had penetrative intercourse, and had gone to pelvic PT before, and they just did the same things over and over again, which makes me so angry. And then she came in to see us, and within 3 sessions, she was like, so I have something to tell you. And I was like, oh no, what? She's like, I'm pregnant. And I was like, what? How? So like, by needling her adductors and low back, it released her pelvic floor. And she was one of those, I had vaginismus, but really was functional vaginismus. And like, within 3 sessions, she had penetrated intercourse for the first time. Whether or not she wanted to get pregnant that first time, I don't know, but yeah, so, yeah.
Thank you so much.
Yeah. Any other questions? We have 5 minutes?
Yeah, you're gonna have to talk to her.
Yeah, I know. The date. She has to be on Instagram. Coming.
Right. Yeah, 5 minutes, sorry.
Any other questions?
I will say that everybody, all the team, they're all amazing.
Oh, thank you. I appreciate that.
So,
I appreciate that. I would agree on bias stuff, because I hired them all. But it's nice to hear from a true patient in the wild. So we have 3 locations. We have Lehigh is the closest one, right by Edna's in the Roller Mills there. And then we have West Jordan, and then we have Layton.
We talked about postpartum a little bit, pre-birth. So
Yeah, pregnancy. Yeah, so we work a lot on prepping for birth, making sure people know how to push appropriately, how to put the pelvic floor out of the way, make sure their hips and body moves well. So similar to, you probably heard of Webster's technique for chiropractors, so we do a similar thing, which by the way, I want to make a Reborn method that's similar to the Webster's technique, where it's like, you know what I mean?
Volunteers tribute. We'll work with you on that.
Perfect. But it's not the same, like it would be different, you know what I mean? Like in our.
You have to be good.
Yeah. But we can work on making sure hips and everything open up, we can make sure pelvic floor moves well, perineal massage and stretching, going over push positions, make sure you breathe properly for what needs to happen. And then we also make sure like everything's open and moving to get baby in better alignment too. So let's say baby shifted over to one side and it's like, I think my baby can move. We'll do a lot, if it's shifted over here, it usually means it's tight over here. So we'll work on a lot of the renal fascia and the fascia in the back, the ribs, and get all of that moving, and then all of a sudden baby goes, oh, hi. And get centered back into. So we help decrease the risk of cesarean, help decrease the risk of tearing, help prep you for postpartum so that learning curve's out of the way. And most of our mamas that come in during pregnancy, we're almost on the far end of the spectrum of like, we almost have to hold them back because they're like, I feel great. I had 2 babies before this. It's the best I've ever felt. I'm like, whoa, you still got soft tissue feeling to like respect. And so like, let's still ease into it and take it slowly and progressively, but you're not just gonna go from 0 to 0, like 360 overnight either. So, but I'd way rather do that than like have to work really hard to like get people back to where they need to be. Yeah.
So we have 2 minutes left on the recording, but we can keep, I've got the iPad going, so if we have any more questions, we can keep it.
Okay, what other questions?
I talked a little bit about, like, all this things, like, not, what do you think, where's that disconnect of like going to see and just have so much respect for like these certain types of doctors,
Yeah.
but then like, what might actually really help them is pelvic floor therapy and why it's not being spoken about.
I think there's a lot of reasons. I think it's a systemic system thing. I think it's a medical education thing, right? I didn't even know what pelvic floor PT was until I was in the first lecture in my PT class. Like, oh, what's this? And it was like one lecture in my entire PT school. So our own profession doesn't even know what we do. That's a problem.
For chiropractors, ours was anatomy, but then it was cables.
Yeah.
A few other things.
Yeah.
When I met her, I said cables, she shuddered. I'm like, I know.
So I was like, no, please don't. Yeah, so I think it's bigger. I think, and for me, because I'm so like righteously angry about it, I think it starts with us, right? I really do. I think it starts with the patient that comes in, it's like, oh my gosh, did you know about this? The provider that says, hey, did you know about this? Hey, did you know it's not normal to weaken your pants? You can go to pelvic floor PT. Oh, I didn't know that was a thing. Great, let me look into it.
So providers do know about that. Insurance doesn't cover. And our claim times are so short, we can't do much for the year, we're bringing them out. And
Where do you do?
I'm nurse midwife now.
Ooh,
I send people to tell them.
Midwives are friends. Our friends, yes.
Yeah.
But you guys are the exception
This
of that.
kind is a self-pay kind that a lot of clients.
Yeah. Believe me, I tried to get in that with us, like, oh, they said no. They don't want us. They don't know what to do.
They know their own.
That's
not this.
I know,
And we know it, but
still take care of it.
we're helpless against
I know.
the system.
I know, I think it's all broken, right? So thank you for referring to public PT. Thank you for referring to public PT. Thank you for referring to public PT. Like I know you
Well,
guys.
I just think people